is seal. So y'all know that I'm kind of quick as I fly through this stuff. All right, so here we're going to talk about all of the biology of the rays and all that kind of stuff, but then we're also going to talk about some of the disease process or of the changes that can have this happen, right? UV lights, it's the most of the photobiologic skin reaction and diseases, okay? It's divided into one of those. Which rays are the worst? UVA, okay? That is what would cause of the more disease process and skin reactions then of the UVBs, and UVC is the one all the way up top. UVA is coming down to us throughout of the day, of the year. It's got the long waves that penetrate deeply. So it's more deep than of the other two. It gets into of the dermis as well as of the fat. If we were having some of the chronic exposure and we're not using any protective agents, then it can have the tissue degeneration. So that's why it is the most common one that penetrates deep. UVB during the summer, high amounts of energy of the corneum and of the superficial. So it's not as like the UVA is. Sunburn, tan, redness, pigmentation, and inflammation. UVC is all the way up in of our ozone layer. So yeah, it's there. This is what it's looking like, right? So we've got all of the UVA that's more red than the UVC. So it causes more of the symptoms and of the damage than of the other two. Phototypes. So we can see up top, it's of the lighter skin. It's talking about the Irish, the blue eyes, red hair, freckles. So that is what is all the way up there. Whereas of 6, it's more that it never burns because of the darkness of the pigment, right? So it's going through all of that area. What is more important about the phototypes is what's read at the bottom of the cancer risk. So of the Northern European, British, of the gingers, right, with of the red, of the blue, beautiful eyes, are at a higher of a cancer risk of the skin. Of the environmental factors as of the amount of exposure. So sun elevation, right? Avoid peak sunlight hours from 10 up until 3. So if you're living up in Denver, Colorado, and you're hanging out with all of the sun exposure, then it's of a higher of a factor. The clouds out there, are they stopping all of the UV? No, they're not. It's still going to come through the clouds. Snow and ice reflect of the UVB back up to you. And then of the ozone, we talked about the UVC, how it stays up there. Okay. Colorado is amazing, but it's high up, and the snow and ice can just be throwing everything at you. Sun protection factor. So basically, it's the ratio of the least amount of UVB energy required to produce of erythema reaction. even though it's going through the sunscreen, whereas that is compared to the amount of energy required to produce the same redness without any of a sunscreen application. So it's like a ratio there. Sunscreen with SPF blocks UVB and UVA, therefore increasing the med needed to produce the sunburn, right? So y'all know we have the sunscreen of the SPF that is like 30, 15, you know, it just goes around. We have some that are waterproof and some that are not. So we have those things out there. Talking about the protection, of course, we talked about the SPF of the 15 to 30 daily. Apply it to the 15-30 again before you go outside. Sunscreen every 2 hours, especially if you have to be out from 10 up until 1500, then we would use the SPF. Wear dark, loose, dry clothing with tight weave, wide brim hat, long sleeve shirt and pants. Oftentimes, if we see construction people outside, they all have, you know, all that kind of stuff. It's 100 degrees outside, but you're wearing all that kind of stuff. Yeah, well, it works. So if we're going to be doing the physical sun protection, that is just to keep it out of the corneum and then also melanin. Clothing is the best protection method, as well as of the sunscreen, right? So we can do some of those things there. The chemical, the water resistant, so if we're getting, you know, the waterproof and resistant, it can help us with if there's some immersion that's there. Active ingredients of the sunscreen. So we've got the topical agents that absorb, scatter, or reflect the UV and the light. Complete protection, we can see how that is blocking the entire UV spectrum, which is of a combination of the blockage of both UVA and UVB. FDA has provided a list of approved ingredients for the over-the-counter sunscreen. All right, so now let's talk about some of the changes, some of the stuff that's no bueno. So photo aging. This is the skin changes superimposed on intrinsic aging by chronic sun exposure. So we can have some texture of the changes, vascular changes, pigmentation, and papular that is acting out. So let's talk about the photo aging of the texture changes. So we have what's called solar elastosis. So that is with all of the chronically sun-exposed areas and presents with thickened skin and yellow hue. So what are most of the sun-exposed areas? Well, it's of our face, right? So you can get this on of the forehead, the cheeks, the chin, the back of the neck, those areas right there. Atrophy, we have learned that with all of our hands and stuff, how it can have some of the atrophy that is going away. Well, this can also happen up on of our lips and the other areas. Thin skin, prominent blood vessels, so you can see those things and easy bruising. So, yeah. Wrinkles of the nuchae, sun induced wrinkling on the back of the neck that forms rhomboidal patterns. You can see all of the wrinkles that are back there. Okay. Vascular changes. Venous lake, round purple vessels, lower lips and ears is where we can see that happen, as is in the upper picture there of the lips. Telangiectasis, that is of our cheek, nose, that is us just seeing some of this, of the veins and stuff that are more pushed out on it. Oftentimes, it's of the areas that are more prominent and out moving there. You can also get some of diffuse the redness. We can have ecchymosis, pseudoscars, pigmentation, right? So we could have some changes of hyperplasia of melanocytes. Again, all of this stuff is inside of exposed areas. What can it be? It can be freckles. It could be lentigo. It could be of irregular the pigmentation, right? So we've got that stuff. Civate, red, brown, reticulated pigmentation with what's that? We already talked about chest and neck. These are some of the pictures of it there, so we can see of the freckles that are on the upper back and neck. Lentigo over there up on of the forehead, but also on of the nose and cheeks. One of these names that are, of course, named after someone important that decided it. Again, names, it is what it is. But what you can see is all of erythematous areas there that have been exposed, and that's what we are looking at there. Same thing on these ones here. So it's all of the neck that is affected more with Civate. The other thing with the photoaging is of the papular changes. So we can have the nevi, we can have the keratosis, the seborrheic elastosis, which we talked about earlier as of the yellow of the papules that are causing this. And then of another name, Rashusha-shot, whatever you want to say. Open and closed the comedones that are there, and with that, you can see some of the EICs. Elastosis, cheeks, lips, forehead. There's that ricochet on of the cheeks there. So how do we treat these? Prevention is of the key. So we need to, as we talked about, all of the sun exposure, of the times, of the locations, of environment, there are those things. We can also do some of the topicals. That'll be our retinoids. Non-invasive but slow because it takes months to take it away. We have to use that over and over. So that would be used. Sunscreen, sunscreen, sunscreen. We need to be using those things for everything, whether the location of the travels, locations, and yada yada. Treats fine wrinkles, pigmentation changes. Da, 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 da. We can also be LeBron James and treat it from its expensive aspects, right? So we're talking about the chemical peels, of the dermabrasion, of the lasers. If we're having some of this stuff, we could also have some of the scarring of the hypopigmentation. So we're taking these things to treat something that is wrong now, but if we do it too much, then it can be wrong again, looking different. We can do these things superficial, medium, or deep. Some of the pictures here are of the chemical peels. So this individual is using it around of the eyes, so you can see all of the steps of that, how it was done, what it looked like right after, how it got a little bit worse with all of the redness, and then healed up and made a beautiful face. All right, so now let's get into the polymorphous light eruption. Okay. Most common light-induced skin disease. Polymorphous light eruption is most common, and it's triggered by exposure to the UV rays. UVB more than UVA. Delayed type hypersensitivity response, endocutaneous photoinduced antigen. So that's what it's doing. Okay. This most common one, epidemiology, is first 3 decades of life. So up until 30, there you go. This happens in the fair-skinned, the females. Inversely, it's not so much more into the latitude. There's an example of Singapore versus of Sweden. Sun exposure, incremental doses of UV radiation based on toleration and resolution. This is essentially known as the hardening of our skin. Morphology, lesions are like the name is, the polymorphous. They're mildly to markedly itchy, grouped, redness, skin of the color papules. It can be back and forth between large, smooth, or evenly surfaced plaques, dark of the individuals. Most common is grouped pinhead size papules in the sun exposed areas. We've got some of the clinical types. So papular is the most common, whereas plaque is the second one. And then there are the other ones, papular, eczema, multiform type, hemorrhagic types. Those are the other types. But the papular is number 1, plaque is number 2. Location. I think that we wouldn't have to say that all of this stuff is sun exposed, because it has to be in order to get the rays. But it's on every single one, okay? V of the chest. So it's the area that is exposed by the shirt. If it's a tank top, it could be more. If it's the uniforms that y'all have on, then it's going to be tied up there. It can also be on the backs of the hands, of the forearms, lower legs. Yeah. We all know that all of the rays can even flow through our clothes. Not as severe as of exposed areas, but it could get into that as well. You can see there that is the forearm. It's also the backs of the elbow and all that kind of stuff. So how will they come in and see us? The onset is usually of the spring and early of the summer. So outside right now, okay? Let's all go out there. Winter, A tanning bed, if you're having 30 of the minutes or hours of this exposure, then we can have some eruption. We can have malaise, chills, headache, nausea, all before of the rash is actually showing us. Once we're healing this up, the good thing is that we're not going to have any of the scar. Diagnosis there, we can see that we're having a delay of an onset. We're having some of the histopathological the changes. Biopsy of immunofluorescent studies, mandatory to rule out of the lupus. Photo testing, we exactly know that it's the lesions when it's of exposed to UVA and UVB. Treatment, steroids, topical 2 through 5. If it is itchy, we can also use some of the oral steroids if it's wide spread, so it's all of the itching everywhere. That's when we can use it. Like everything that we were talking about throughout this entire lecture, sun protection and limiting sun exposure is number 1. Let's see. We can also use some Sorolin UVA, so PUVA, and then hydroxy chloroquine. Last line. That is of the V, right? So that's more of all of the sun exposure area with the tank top. There's what we talked about of the forearm, of the elbows area. Lower legs, that's those individuals who love to sunbathe. So they're all down in their bathing suit, exposing all of that. Prurigo, hereditary of a light eruption. This is oftentimes seen with the Native Americans of North, Central, and South America. This all starts off in childhood, and it's females more than males. There's, because of the fact that it is hereditary, there is some of the family history. This is more, as I just said, with the children, and then as they grow older, then it can heal up. These things happen with itchy of the papules, plaques, and nodules, and the face is the most common site. They can have some of the bleeding crust, some eczema, the lichenification, actinic of the cellulitis, so of their lips. We're going to treat this the exact same way what we talked about with the polymorphous. Same thing. Here we go. We have this onto the arms, hands. Phototoxic reactions. Non-allergic skin responses induced by topical and systemic agents. So what are the treatments that are causing us to have the toxicity? As we said a little while ago, this can be absorbed, whether it's a topical treatment or of an oral medication. Not only is it the medication, but it's also of exposure to the rays, so they work together that can actually cause that. Again, that's exactly the medications both working with the UV lights to have that. Some of the symptoms that it could occur if it's maximum, the tingling, redness, the burning, edema, vesicles, bullae, streaking, and desquamation. Phytophotodermatitis, sun-exposed areas, bizarre patterns of inflammation. It'll have some of a redness rash with vesicles that can heal with the hyperpigmentation. Drug eruptions, generalized intense redness and sun-exposed skin, forehead, nose, cheeks, ears, neck, V of the chest, forearm extensors in the back of the hand. So again, sun-exposed areas. Here's the medications that can cause that. The topical perfumes, lotions, we can get into the plants, right? So the limes of fig, hogweed, grass. In regards to the medications, the one that is the worst and can cause significant toxic are your TCNs, so tetracyclines. With other the medications that are lower, we can see of the fluoroquinolones, the sulfas, ibuprofen and naproxen, yay. ACTZ, it's going down. Like I said, the number one is all the way up at the top. Let's figure out what it is that could be causing this area and discontinue, change it, or decrease it, or make adjustments to that medication that is causing it or being in contact with that stuff. Sunscreen, topical steroids, systemic steroids is often necessary because of these things being severe. We can use the PUVA, but we could have some of the toxic stuff there with the redness of the itching. If we have to use it, we have to use it, but it's a last resort of what we will do. All right. Vitiligo. We can oftentimes see this with more of the darker skin. So, you know, it can be some stuff that stands out to you. Why do you have a white spot in that area? What causes this? It's because of the absence of melanocytes that's then making it more white in the pigmentation. Autoimmune, genetic, males equal of the females. It can happen in either race. 50% before age 20, so it can be, it's not going to happen in all of the young and healthy skin. It'll be more so as we get older. Type A and type B. Type A is most common. It's symmetrical of the dorsal hands, face, body folds, genitalia, the openings. Kovner, that can be specifically at of the elbows and of the sunburned areas associated with the halo nevi. So all of the type A is the picture that you see right there. Whereas of type B is asymmetric. right? So it doesn't cross the midline. It's not just of a circle like we see there with the type A. It would be spread out. Earlier onset than of the type A. Associated concerns. This could have some of the psych stuff, whether that's of social interactions, because there will be some individuals looking at you like, what the hell happened there? Again, it's with the darker the pigments, right? So you can see that. Of concerns of the eyes and ears, of the retinal epithelium, that would put you at a uveitis risk, of the labyrinth, causing us some of the hearing issues. Meningitis, this can also then combine with alopecia, hypothyroidism, Graves, Addison, anemia, type 1 of the diabetes, and of course of a melanoma of a skin cancer. Again, this is some of the things that it could get us into. So we talked about of the meningitis and all of the upper things. Here are all of the locations. So if it is of a generalized, then it's all over, whereas it can be of the localized into those areas. The reason why with the vitiligo in the pictures, that is of the white spots, not so much as it looks like erythema everywhere. Look at the pictures and it's of the white areas. We can use of a woods lamp to actually show us where the areas are. Even if it's not white yet, it could still be some of the location that it will spread into. Treatment, the only thing that we can do is what they are asking for. So we could do some stabilization of the pigmentation process. We can try to put some stuff into it to actually build up the pigmentation back. However, some of these things will not work or respond. Other things that we can do is the topical steroids, vitamin D, the calcium inhibitors, of the phototherapy, laser, the camouflage, just to put those things over that. Do not discount the psychological stuff. This is an individual who has had some changes to their skin that everybody in the entire world can look at that and wonder what the hell happened. So here's one that is not generalized. It's, not of a single of a type A. So this one here is type B, as well as this one here. It's all over the place. Something else there. Okay, we're getting there. So IgH, this is of the gutate hypomelanosis. Asymptomatic white spots on arms and legs. Again, sun exposed area of middle-aged and older adults. So we can see the pictures right there. It's of a darker skin, and now it's starting to get some of the white spots. Idiopathic. Etiology, I don't know. Why is it happening? Seborrheic of the keratosis. Can all be in of the same areas that the IGH is working on. White spots with sharply demarcated the borders. So it's there just like of a type A of the vitiligo. What is this happening? It's because of the fact that we have a decrease of melanocytes. Located on exposed areas of hands, forearms, and lower legs in middle-aged and older people. So you can see of the sharply white spots. What else could this be of our differential? It could be fungal. It could be just the nevus that could be there. Again, prevention. I should just get a tattoo on my forehead that says avoid sun, because that's on everything and all of this stuff. We can use the retinoids. We can use some topical steroids. We can freeze it, the dermabrasion, and of the cosmetics, right? So go to Sephora and buy some of the most beautiful stuff and rush it on. There they are. Demarcated, sharply borders. Again. Lentigo. Solar. Tan to brown macules due to localized proliferation of melanocytes from acute or chronic exposure to sunlight. Most common, this is seen in adults. 90% of Caucasians over the age of 60 have their liver spots because of the fact that they're tan or brown. It can also happen with some of the fair-skinned children, so lock it up. Again, there you go, sun-exposed sites. Lesions may be round, oval, and slightly irregular. Scattered, discrete lesions, sharply defined, light yellow, light to dark brown. Again, just put it on my forehead, like I said. Chronic sun exposure, hyperplasia of melanocytes, and increased pigmentation. So what could also be some of the differential? So melanoma of keratosis, of the freckles, of the keratosis, stuck on appearance. What is in the picture over there is more so all about the melanoma. So it's showing you the ABCDE, which we will go through all on the next block. So that's not testable in this block. None necessary for the management. We can do some of the cryo, we can do the retinoids, the laser, and then some of that other stuff that is combined together. So what do they look like? They look like that. So this one is of the back, or the back of the neck. You can see it's the liver spots, right? So it's tan up to brown. Again, it's the back of the hands. All right. Last one. Melasma. mask of pregnancy. So it's symmetrical brown of the hyperpigmentation, face and neck. Develops slowly without signs of inflammation. Talk about the fact that it's of a mask, so that mask will be faint or it could be dark. Hormonal. Oftentimes it'll be seen with some pregnancy, the contraceptives, estrogen, progesterone of the therapies. May not fully resolve after having of the baby or taking away of the OCPs, but that can be most of what is caused by this. Thyroid, again, Sephora for wonderful of the cosmetics, and if we're using some of anti-seizure medications, then it can have the phototoxic phenytoin. We have 3 of the patterns. So we have the central facial, forehead, cheeks, upper lip, chin, malar, cheeks and nose, and mandibular. I probably don't have to tell you all where that's at. Again, yada yada. Minimize exposure. Sunscreens to block both UVA and UVB. But we also can prescribe some of the medications here. So the hydroquinone, most effective topical bleaching agent, and it's available without a prescription, but that's cost. Twice daily, and stay inside of a dark room, not outside. Acid, retinoid, significant improvement, but it takes a lot of time. Like it says right below there, up to a year. Triluma is a combo of all of that stuff put together. If we do have that, that can take up to 8 weeks being used every day. Because it is of a combo, it is most effective if we're not just using one, put them together, and there we go. You can also have some of the chemical peels, which we saw of the pictures prior, lasers and camouflage, aka Sephora. And I only know that place because my volleyball girl loves to go in there and shop. I don't take her, but her damn mom does. She has more makeup than my wife. All right, that is that. These are all of the lectures, 4 of our Block 2 tests, which we will be doing on Monday morning, okay? We will be in here at the same time on Friday, and I will do a review of all of the lectures, okay? All right, I will knock on the wall, and if he's gonna come and chat with y'all, then yes. But I'm putting y'all on break. All right?
Go ahead and take 10, and then Sardis Biz is going to come and give our out processing brief.
Okay. I will let him know that too.
Joe asked me about
He should be on the way. I told him probably 11.
second
He's in this area.
Circulate.
Yeah.
I asked him,
pretty much everybody.
And I'm sure he wasn't.
Conversation with him relative.
Are you gonna? Are you